Welcome everybody to the latest installation of the Research in Progress webinar series for the Robert Wood Johnson Foundation's Systems for Action research program. Thanks so much for joining us. If you're a new attendee to this session, this is a session that we do quite regularly, usually about twice a month. It's a chance for us to drop in on one of the research studies that is being conducted through the Systems for Action program, to hear from the research teams about their experiences in conducting the study and what they're learning so far. Typically, at some point midway through the study, to give you give our audiences some almost real-time insight into research around aligning health and social systems, and also give our audience members a chance to interact and dialogue with the research teams about what they're learning and what it all means. For those, again, who may be new to the Systems for Action program, we are a signature research program of the Robert Wood Johnson Foundation, and our focus in S4A is in testing novel strategies for helping delivery systems in medical care, in public health, and in social services work better together. This concept of system alignment, looking at ways of helping delivery systems in those three sectors align their activities and actions and produce improved health outcomes, and especially advance the cause of health equity. I'm Glenn Mays. I'm your host for today. I have the privilege of directing the National Program Office for Systems for Action program. I'm a faculty member here in Colorado, based at the University of Colorado School of Public Health, where the National Program Office is located. And we're really fortunate today to be joined and to feature our Connecticut-based research team to present work on their study looking at transit and treatment, ways of leveraging transit systems and policies to improve access and outcomes for populations experiencing substance abuse and mental health risks. In particular, we're going to hear from the three names you see on this screen, presenters from our Connecticut-based team that include Dr. Jeffrey Cohen, and Dr. Carla Rush from University of Connecticut, and one of their key partners, Steve Hewlett, at the Capital Region Council of Governments. So next slide, just I think a little bit more introductions to our speakers today. Dr. Cohen, again, is at the University of Connecticut. He's an economist by training, a professor there at the university, has expertise in both transit policy issues as well as real estate and the economics of real estate markets. And he's also done some really important work in public health as well, more recently. So he's well positioned to study the intersection of these issues in terms of how substance use treatment services intersect with public health systems more generally, and with these other issues around transportation and land use issues. We'll also hear from Dr. Carla Rush, who is also at University of Connecticut at UConn Health, the academic medical center there. A clinical psychologist by training, expertise in addictions treatment and various modalities of treatment. And then we'll also hear from a third stakeholder engaged in this work, who provides some commentary about this work and what it may all mean. Stephen Hewlett, who is with the Capital Region Council of Governments, and is engaged in emergency preparedness activities that are conducted by the Regional Council of Governments, and actively engaged in the medical response system there as well. He's got a long history in public health, has worked in leadership positions in local public health in Connecticut, and has also been president of the Connecticut Association of Directors of Health. So really great team, really innovative project to feature today. And with that, I will turn it over to Dr. Cohen.
Thank you very much for the introduction, Glenn. And I want to thank the entire Systems for Action team, including Glenn, Sedina, and Carrington. You've been great to work with over the past year and a half or so of the project. We really appreciate your support. I also want to briefly acknowledge, in addition to Carla and Steve, who were already introduced, I want to briefly acknowledge two other important team members, including Professor Shane Murphy, who's an assistant professor in health economics at the University of Connecticut, and Ruth Fetter, who's a research assistant at UConn Health. Both of them have been very instrumental in our moving forward with our analysis, which we're going to be discussing this morning or this afternoon, depending on where you are. We all know that, or many of us know that access to substance use disorder and mental health treatment is a crucial issue for a number of reasons. One is that illicit substance use and prescription misuse cost our economy more than $600 billion a year. That's billion with a B, according to a NIDA, National Institute on Drug Abuse report in 2020. And there are other additional costs, including indirect costs such as lost productivity and crime, that add on to this further. And if you were to sort of break this down, it would cost about $4,700 per year on average for a typical patient to receive methadone treatment, according to NIDA in 2020. And since there's about 3.7 million people who are ages 12 and older receiving treatment at a substance use disorder specialty facility in the US each year, according to SAMHSA in 2019, you can just do the math and realize that this is a very costly disorder to treat. And it's very important, not only because we want to get an understanding of the costs of treatment and how we can possibly treat people in a more cost-efficient way, but it also drives health disparities because of the fact that it's so costly. It excludes, in some situations, people who don't have the ability to pay or don't have the insurance to pay for it. And so the equity issue is something important as well that we will be exploring, and we do explore it in part through incorporating demographics into our analysis. We're going to dig deeper into the demographics a little bit later on in the project. The substance use disorder problem has been exacerbated by the opioid crisis as well, because there's been a marked uptick in the number of people who need substance use treatment due to the opioid crisis, as well as due to COVID, which is forcing people to be more isolated and causing some people to turn to illicit substances in order to try and get themselves through the crisis. Now, there's an important aspect. One of the important aspects that we consider in our analysis is, how do we get people back and forth to the treatment sites from their locations of residence if they're not in an inpatient program. So Carla Rash and some co-authors of hers have done a study looking at patients initiating substance use disorder treatment in Connecticut and Western Massachusetts, which borders on Connecticut. It's just north of Connecticut. And she has a sample of around 1,200 patients there. And she found that more than 50% of them did not have a driver's license, which is important because, how do you get to treatment? Not only is it important because they didn't have a driver's license, but people who did have a driver's license, nearly 40% of them did not have access to a vehicle. And it's also probably the case that many of those who did have an access to vehicles were not in the right situation to be able to drive them, given their disorder. So getting people back and forth to treatment is an important issue, and it's the social services aspect of our three prongs that we look at here in this project. One of the prongs being medical treatment, which is the substance use disorder and mental health treatment. We also look at public health. That's where Steve comes in terms of his contributions with the advisory panel, where he'll talk much more detail about that later, but we have state agencies, public health agency, we have the Department of Mental Health and Addiction Services, we have the Department of Transportation in Connecticut, we have many other providers are on the panel, as well as some academics as well. So, one of the things we're wondering about is whether or not strong systems, transit systems, can help with treatment outcomes, and in helping with treatment outcomes, perhaps impact the operating costs of substance use treatment providers. We're not looking here at the treatment costs per se. This is an important distinction to make. We're looking at the total operating costs involved with the entire operation of clinics, rather than just the specific costs of treating patients. And that's important because a lot of providers receive revenue in the form of grants from the state government, and they're typically reimbursed for a large portion of what it costs them to treat people, but there are other costs as well that are important to take into consideration that involve the operation of the clinic, and that's the important thing to keep in the back of your minds as we're going through this. There have been some past studies that have found the operating costs are decreasing with more patients, but there's a lot of variation, and it's unknown. So there's several studies, including by Duffy et al. 2004, Beast and Blakeman et al. 2007, and Dunlap in 2008. But it's unknown why there's such variation across providers within states and across states. And this results in challenges for state agencies when it comes time to make decisions as to how to reimburse providers. So what are some of the things that proximity to treatment facilities of transit might do? Well, one is it might make it easier to fill up any unfilled appointments at providers. Okay, so it's one possibility is to increase the patient volumes. Another is if you're getting more reliable transportation, it's more likely that you're going to not miss as many appointments. So it will hopefully reduce unbillable clinician time. It could also push down on the unit cost curves and create some economies of scale. The example of economies of scale I like to give to my students often is, suppose you have a truck and you're trying to fill up the truck with packages. If you fill up the truck halfway and ship the packages in the truck half full, it's going to cost you more per package to ship that than if you filled the truck up completely instead of leaving it half empty. And similarly with substance use treatment providers, if you have empty space in your facility, you're still paying the rent on your building. We're thinking about operating costs here, right? You're still paying the electricity. So if you can fill up your clinics and not have any empty slots, it's more likely that the cost per patient is going to go down. And if you have a more steady stream of people coming in because they have access to transit opposed to haphazard ways of trying to get there, that may reduce costs as well. And finally, if you integrate mental health and substance use disorder services together, it might also produce cost savings. And according to a SAMHSA 2020 report, only about half of treatment providers in the US had special programs for patients with co-occurring mental health disorders. So, it begs the question, well, how do those types of providers differ in terms of their cost structures than those that treat only substance use disorders separately and only mental health disorders separately? So those are things that we're going to look at later on in this study, but for today, we're going to focus on number one here. So what do? We use a quasi-experimental empirical econometric approach, basically a regression approach, to try to answer question number one that we're going to talk about today. Questions 2 through 4, we're still working on. We're going to come back to you next time and hopefully talk with you more about that then. But what do we mean? Why do we need a quasi-experimental approach? Well, if you're a scientist, you might want to try to conduct a controlled experiment and see how your outcome variable is impacted by various treatments, for instance. But with looking back on this type of data that we're using, where we have data on the treatment providers, numbers of clients treated, and their operating costs, it's not possible to conduct a controlled experiment of how substance use disorder treatment providers make their decisions. So instead of that, we can use a quasi-experimental approach, which is essentially a statistical approach where you use regression analysis to control for other factors that are expected to influence costs, just like you'd have a control group if you did a controlled experiment. And that is what is going to hopefully enable us to say something about how treatment costs are different after a new transit line is opened for providers that are close to that transit line. Okay, so the other 3 things here that we have listed, number 2, 3, and 4, we're gonna look at later on how transit impacts provider costs who offer comprehensive versus limited substance use disorder services. How does transit impact provider costs who offer substance use disorder treatments separately versus integrating the two? And for transit improvements, what we're going to look at is treatment cost changes for treating patients with different outcomes. So instead of just looking at the number of clients treated, what we're going to do eventually is look at how do outcomes interact with costs here, because it's important to not just say count the number of patients. You might treat 100 patients and only 10% of them get better, but if you treat 50 patients and 80% of them get better, you're going to have better outcomes than the provider that treated 100 with a 10% success rate. So and that you would expect that to impact costs as well. And then how is that all related to client demographics and equity is an important aspect that we're going to look at a little bit later as well. So the data that we use is at the provider level. We get that data from the state substance use treatment agency called Department of Mental Health and Addiction Services. And we also obtain Internal Revenue Service tax data for each provider that we merged with the substance use disorder treatment data. So the substance use disorder treatment data, you'll see in a couple minutes, it includes demographic information on average for each provider in each year. And we have, I believe, about 8 years of data. It includes some other variables, including the number of clients that were treated, and we merge that with the financial data. Now we're expecting to very shortly to get some additional, even more rich data, because what we have right now is the location of the provider, but the provider could have many programs under it, and in many cases they do. And so what we are going to be getting shortly from the state agency is the addresses of every program that is in that is a part of each provider, and there's on the range of 1,500, I believe, roughly, programs in the state of Connecticut. So what we'll be able to do is to say provider X had 8 programs that were near transit. Provider Y had 3 programs that were near transit, and then we can control for that rather than looking where the main address of the provider is relative to the transit stations. So the other thing we're going to merge here with is we have demographic data, and we also have the location of CT fast track stations in Connecticut. So CT fast track, just to move on to the next slide here. Oh, I'm going to go to CT fast track first, and I'm going to step back. CT Fast Track is a bus rapid transit line that opened in March 2015 that connects 4 towns in the greater Hartford area: Hartford, West Hartford, Newington, and New Britain. And this is an important route because there are a lot of people who live in New Britain and Newington who don't have access to automobiles as not just substance use clients, but people in general. And so having access to this transit service enables people to get where they need to go, not only for jobs, but our hypothesis is potentially for substance use treatment as well. This came from a graphic that I had used in a study that I had developed with a co-author in a study on the CT Fast Track bus rapid transit system and the impacts on real estate in Connecticut. But what we see here is these yellow dots are the 11 different stations of the CT Fast Track. It's a dedicated bus rapid transit line, so it doesn't have to drive through traffic in the city streets. It's very reliable. You know exactly when it's going to come, when it's going to get you where you need to go. And so it's potentially a good social service to try and help clients for substance use and mental health disorder treatment who need to get where they need to go and are unable to drive. We'll go back to talking about the rest of the data that we have. We have roughly 1,500 programs over 8 years with 175 providers. We aggregate the program types into two categories: outpatient and inpatient. And we focus primarily on outpatient because inpatient doesn't need transit in the same way as outpatient does. And we focus on the fact that the CT Fast Track opened in 2015, and we have data going back before 2015 all the way to 2012 and up to 2019 on the Department of Mental Health and Addiction Services data that we're using. So we're able to do a quasi-experiment where we can look at the after versus before the opening of the CT Fast Track and see how costs are different after versus before for providers that are close versus far from CT Fast Track. Here is the summary statistics of some of the key variables that we have in the data. We have the average number of clients per facility in a given year is around 3,400 clients. We have around 1,500 observations total. That's the 175 providers times the 8 years roughly. And we see that about 17% of the providers are within 1 mile of a CT Fast Track station. And the average annual operating cost for the providers in our sample is around $21 million. They have around $9 million in assets, and the average salaries paid out are around $11.3 million. In terms of age groups that are treated at these providers, we have the most common group is age 26 to 34. We have around 23% of the client population is in that age range. And then around 43% of the clients are female, around 12% are Black, and around 15% are Hispanic. One other thing to note is that for these roughly 175 providers, these in total includes in the range of 32,000 to 39,000 client interactions per year. And so one of the things we find here is that providers who are close to CT Fast Track stations see a decrease in incremental expenditures and a small increase in the number of clients. We'll go into some additional detail here in showing you what we do. So this is a little bit of the nitty-gritty here. We use what's called the difference in differences approach to try to have what we call an identification strategy to look at the causal effect of proximity to CT Fast Track on the operating costs. That's the first equation that says op cost IT. And we also develop a regression that has basically a logarithmic dependent variable, and then in terms of operating costs. and then a logarithmic explanatory variable in terms of the number of clients. And we look at the coefficient on the regression, which is beta 1 in general. But what we do here is we build that into the difference in differences approach. So what we do is we look at how the elasticity of costs changes for providers that are close to CT fast track after the opening of the bus line. And that's the key variable of interest here. So what we have in this slide right here is 3 sets of regressions. I'm going to ask you to focus your attention on the first one, the first column. Sorry, I just accidentally moved ahead. The first column where it says log of operating costs. So the coefficient on the year and distance interaction term is negative and significant. So what does that imply? That implies for providers that are close to CT fast track after CT fast track opened, we see about a 3% decrease in their operating costs, and that is statistically significant. Okay, and the R squared here is very high, it's 0.996. We include fixed effects for the providers as well as for the years. We also have demographic controls in this regression. So that's interesting. But the other question that we're wondering about is, how do the incremental costs change? How do the costs, when you add another patient and that leads to higher costs, how do those incremental costs change when you're close to CT fast track after the opening of the stations? And what we see here, this is in the second column in this slide right here on the right. The term we're interested in is the interaction here between the number of clients, the distance indicator, and the year indicator. And so we call this a treatment effect because the treatment is being close to the, and we're not talking about substance use treatment, we're talking about treatment in terms of statistical analysis or in terms of the identification strategy. Being close to CT fast track after the CT fast track opened is the treated group. The control group in our quasi experiment is everybody else. So being in this treated group leads incremental costs to fall by about 4% when you double the number of clients. Or in other words, if you were to increase the number of clients by 10%, you'd see about a 0.4% decrease in the incremental costs of treating patients. So that is pretty interesting to us because it basically implies that if people are close to the bus stations, then if providers are close to the bus stations, then they can achieve some significant cost savings from treating additional patients. And we have all those other issues that we talked about before that could be potential explanations for why that happens. So the implications are that if you're looking just at utilization, which I didn't really talk about in those results, but those results are in the table. The opening of CT fast track had a negligible effect on utilization, but spending fell, operating costs or spending decreased at facilities that are close to stations, and they didn't change significantly at facilities that were not close to stations. The other thing is that the incremental spending per client fell at facilities that were close to stations, and it increased slightly at facilities that were not close to stations. So we do see some cost savings, some expenditure savings for operating costs for providers that are treating additional clients when they're close to the CT fast track stations. What are our next steps? Well, as I mentioned, we've been focusing on provider locations, but we can hopefully get an even more rich sense of what's going on within each provider when we incorporate the individual program locations, which we're going to be obtaining from Department of Mental Health and Addiction Services. We're also going to incorporate outcomes as regressors. We're waiting for that data from Department of Mental Health and Addiction Services, as well as data on the type of substance that people are being treated for. And then we're also going to consider the demographic access issue, which is the equity issue, and that's aim number 4 that we showed you before. And we're also going to look at what happens if providers offer multiple programs, inpatient versus outpatient, or substance use disorder and mental health together versus offering them separately. And those cover the other aims in our project. Finally, where are these cost savings coming from? Do we see a change in spending on client attendance that is reduced as a result of the new transportation options? We're going to dig a little bit deeper into that, and part of that is going to be what we discuss in more detail with our outstanding advisory panel. That is, from what I've heard from some others, is it's a unique advisory panel in the state of Connecticut and elsewhere, because we bring people together from different sectors, from the social services, from the medical services, and from the public health sectors, to try to figure out what the answers to the previous questions imply for system alignment, and then hopefully engage in some discussions of what we can do to encourage system alignment. So with that, I'm going to turn it over to Steve Hewlett, who is the head, or the chair of our advisory panel for this project.
Okay, thank you, Jeff. No slides here, so you're just gonna have to stare at my name for the next 10 minutes, I guess. Anyway, the advisory panel is part of the grant research initiative here, and it's something that Jeff had reached out to several of us to get it started. The advisory panel now has 15 members, including the research team, Shane, Jeff, and Carla. But there's 15 members. I think Jeff made reference to the state agencies that participate: Department of Transportation, Department of Public Health, Department of Social Services, and Department of Mental Health and Addiction Services. Those are 3 sort of siloed programs to a certain extent here in the state, with separate commissioners, but they all participate and freely share opportunities for information that they may have in their office, within their jurisdictional offices, so to speak. Some of the funding, some of that data certainly is generated by grant funding, and I think that's where the advisory panel is helpful to the researchers in trying to guide that research, with the fact that some of this is grant funded, so it's the deliverables are focused on one per action or activity of substance use and substance treatment. So the data can be clarified, so the researchers know what that data is actually intending to do. Our goal is certainly to move forward to satisfy all the goals of the research, to reduce costs, to align services, and to just improve overall outcomes of substance abuse use and treatment programs. We meet every month. So we have a monthly meeting. It's scheduled on the 3rd Tuesday of every month. We have a set agenda. The agenda is pretty simple and pretty clear. We usually start off with just a program update from Jeff or Carla. Then we have a presentation, and the presentations are often the panelists themselves, especially when we were new. Every panelist got an opportunity to share their programs and services and their perspectives on the impact that transportation has on those services. And or Jeff or Carl would ask them what the impacts of transit are on their services. We also have the opportunity where we get research updates. So at those points in time, the research team, Jeff, Carla, Shane, will present some of the concepts that you just saw in Jeff's slides, and the advisory panel will react to that. And it's their opportunity to ask questions of the researchers at that point. Well, where did you get this? What does that number mean? Is that reflective of actual practice at the community level? So that practice at the community level, the subject matter expertise that brings, is, I think, one of the things that really heightens and strengthens the research initiatives here. For example, at our last meeting, which was just last week, one of the featured updates was a follow-up from about 6 months ago when one of our advisory panelists had announced that he had received, or his agency has received as a charitable gift, a shuttle bus. And the shuttle bus was something that we were all interested in knowing because it was a real-time study of costs and experiences with implementing a shuttle bus service directly for their clients. When we asked in the follow-up question, it was quite interesting what we got for an answer. And that was that the shuttle buses had a significant amount of downtime due to vandalism here in central Connecticut, and I presume elsewhere across the country. The stealing of catalytic converters has become very lucrative. And he reported that they've had the catalytic converter cut from the bottom of their bus twice, and twice then had to go back and have that renewed. Then he said after the second time they got wise and put a steel cage around the catalytic converter. And then what happened was the vandal who came to once again cut off their catalytic converter decided to instead, out of frustration, damage the side view mirrors. So then they had to get the side view mirrors replaced. So it's while that doesn't fit into the formulas that Jeff was sharing, these are some of the dilemmas that actually add to some of the central. Same vendor, same agency had bought a building in the central business downtown Hartford, if you will. And the question was, well, what factors created that? It was something that was in the press. And so Jeff and the research team were curious as to what the implications were for doing that, specifically because it just happens to be near the bus terminal, if you will, also the busway that Jeff referred, and also the train station. And did that figure into their expectations for client services? So that led to an interesting discussion for a variety of different reasons, but to an extent, yes, that location and the access to that location was factored into that decision to buy. There were other business decisions as well, mind you. And then another interesting one was back in August when we had as a presentation Rashni Vareen, who is an overdose response technician out of Waterbury. And she was able to present the Waterbury model, where the Department of Public Health, where she is the overdose technician, the Waterbury Police, and Waterbury Hospital work in conjunction with substance abuse and substance use clients to get them into treatment and to try to maintain and sustain their treatment plans collaboratively. And the transit issues of that were pretty entertaining from the standpoint of getting to the client or getting the client to the specialist, getting the client from the hospital to a treatment center, getting them from a treatment center to home because it's a regional program. So it had a variety of different components to it, but it also showed how three entities, public health, law enforcement, and healthcare could all work together in the city of Waterbury. And the program was certainly being very successful. I believe it's only been up and running for about 2 years, if I'm not mistaken. So those were the types of things the advisory panel engages with the research team on. Those are three sort of examples of the kind of follow-up that we present, at which time the meeting always ends with questions and answers and clarifications that the research team might want to take away from those practice-based, community-oriented studies. We've certainly heard a lot about the statewide contract for transportation. That's probably something that we will continue to look at. It's had gone through some number of changes, as we've heard, that probably wouldn't appear normally in the data. But what has those impacts been? I think Jeff and the research team are looking into what those consequences might be. So from the sort of systems change component, the advisory panel is always looking for a policy solution, be that a legislative solution, a guideline solution. As Jeff and the team have now started to dig into the research, one of our tasks as the advisory panel will be to try to figure if there is some place where we can make a sustained systematic change And the best way to do that would be through policy or legislation of some sort. So that's what the advisory panel is moving towards. And we look forward to Jeff's and the research team's evidence to support whatever that systems change may be that we can make to improve transit and treatment. So with that, I'll stop there.
Yeah, Steve, thank you very much. Glenn, did you want to jump in at this point? Or?
Yeah, well, I was going to say, if you guys are ready, let's open it up for some Q&A. We've heard some wonderful things about what this project is learning and what some of the implications may be for stakeholders in policy and practice. We now invite those of you who are with us online to submit questions or comments that you might like to add to the discussion at this stage. If you're with us on the webinar portion of on the online webinar portion of this event, you should be able to see a Q&A button down on the lower middle portion of your screen. And so if you can just click on that, you can type in your questions. Unfortunately, we're too big of a webinar to open up microphones and hear you, but we'd love for you to submit your questions. Type in your questions, and we'll go through them as we go.
Glenn,
please, Jeff.
Can I make a follow-up comment to a couple of things that Steve spoke about while we're waiting for people to type in their questions?
That sounds great.
So one of the key objectives from the start of the advisory panel was to try to get people comfortable talking with each other, right? So we had in these meetings, we have providers, we have Department of Public Health, we have Department of Mental Health and Addiction Services, we have the Department of Transportation, we have people from the UConn Med School, we have people from the business school, and we have Steve from the Capital Region Council of Governments, which is sort of an umbrella organization for a number of different areas. They work on public health, they work on transit. And so these people don't normally talk to each other that much. It's nothing intentional. It's just that their paths don't always cross for some of these stakeholders. And so our goal is to get them comfortable with each other, talking with each other. And especially in the beginning where we didn't have research results yet to present, we wanted to get people, just feeling comfortable to chat and talk about their organizations and what they do, so that now once we're starting to get the research results in, we can try to say, okay, let's come together and start discussing possibility for system alignment and how we can help you guys work together and to try to achieve that. So that's one of the big objectives of the advisory panel. In addition to us telling them about our work and having them feel comfortable working with each other, we want to try to foster this environment to encourage system alignment.
Fantastic. Thank you, Jeff, for that insight. Just one kind of meta question I have, I'll put out there and see what reactions are. So that, I mean, this is a really important study, and as you're finding evidence about, again, the benefits to systems and society from having providers in closer proximity to transit, how do you anticipate navigating the decision making about how to respond to those findings, and which systems need to do what actions to bring more proximity between providers to transit? Because you can think about, there's multiple ways of making that happen. The transit agency can change their routes in their services, providers can change their location, or providers can sponsor initiatives like you said, the shuttles, provider sponsored shuttles to connect into transit, or even there's opportunities around shifting housing policy for the people that need these services to bring that more in alignment, more proximate to both transit and services. So how do you navigate those issues of who intervenes and who makes a change to bring these into alignment?
Yeah, that's a great question, Glenn. So we're starting to explore it a little bit by hearing what people have done in the past and what works and what doesn't. I mean, the shuttle example, in some of the neighborhoods where the providers are located, the crime rates are a little bit high, and so we're seeing that if you want to have a shuttle of your own, that's a reasonably newer vehicle, for instance, you're going to have a risk that it's going to be vandalized, that parts might be stolen for the purpose of resale of the more valuable parts. So we're seeing that may not be the most cost-effective way to try and align. On the other hand, we did see an example where one provider purchased a building that was closer to the bus stations than where they were located previously. So as we get a chance for them to move in and see how that goes, we're hopefully going to have some information as to how that's working for them. There's also some rideshare services that we learned a little bit about that a lot of these providers participate in, and that's another option that is, one thing we heard from one of the providers is that sometimes when people take the bus, there's distractions and there's potential things that they, other activities that they could get involved in that they might not if they were in a ride share, for instance, where they were in an Uber or a Lyft, where there weren't other people around who are potential, enablers, so to speak. So we're just trying to get a sense of what people are doing, what has been working, what hasn't been working. And then as we get that information in, Steve alluded to the possibility of trying to engage some of the legislature, possibly, to try to see if they could try to help us with some of this. In terms of the specific bus rapid transit line, it would be really hard for them to change the routes of that because that's built mostly on a dedicated pathway where there's no traffic. So that would, while you would potentially help some of these providers get clients to them more efficiently if they were to go off the route, then you're taking everybody who's using the bus for the purpose of reliability and speed. You're kind of making their trips a little bit longer. So there are other more local buses that could potentially be used for that type of a purpose that you can connect with, for instance, on the CT Fast Track line. So what you can do is you can get off at a stop and then hop on a local bus. And those might be ones that would be more likely to be willing to alter their schedules and their routes to try to align more closely with appointment times, possibly, and to come closer to the neighborhoods where the providers are. Hopefully, we're going to get more of a sense of that once we get the program location data, which we're really expecting in the next 2 weeks or so. And so, we can tell you hopefully then how many of those are close to local bus routes in addition to the CT Fast Track line. So it can get a little bit complicated, but I think talking about this with the stakeholders has really been helpful, not only for the researchers, but also for the stakeholders to generate ideas for how they could potentially navigate the decision making of how to respond and in what ways we might want to think about alignment as we move further on into this project.
Yeah, in part, I'd say, Jeff's statement about safety and perhaps security of travel, as well as perhaps just, trying to be somewhat private about your affairs, I think is something the advisory panel is very sensitive to, because that's their clients, it's their individuals, it's to a certain extent their responsibility. Our newest member is down in the New London Groton area, and that's old New England seaport kind of village, very densely populated. And he talked about how many of his clients can walk to the facility. So walking is still part of safe streets, it's still part of transit. So it's still, how do you make the streets safe for those folks, if the sidewalks are narrow, if they don't have street lights, if they feel unsafe and insecure. So a variety of sorts of things I think that the panel brings to the researchers' attention, or maybe some of those current local initiatives like a safe street program. Some of our facilities are residential, so their transportation needs are a little different, but they all have outpatient components. We have had the opportunity to discuss a lot about telemedicine, thanks to COVID. The data is not in on telemedicine, but what does telemedicine do to transit, especially in substance use counseling? And basically, it's not as good as face-to-face. So, but we've met as a group throughout the COVID experience. To be honest, that's sort of when we started. So we've watched that component of technology versus transit kick in as well, and what will that mean, or and what's that do to the outcomes of the counseling thing. So that's been a great topic. Jeff's completely correct. Built infrastructure like the busway, that took many years to get it implemented and running. You can add more bus stops, but I don't think you're going to be able to change the busway corridor very easily. Perhaps you could extend it, Jeff. Perhaps it'll go east of the river. What do you think? That might be good. But anyway, that's just another aspect. The safety component of the clients and the staff does come up in our conversations with the various agencies and panelists. And I do regret that I didn't mention UConn as one of the members, because it is both the business school and the School of Medicine that participate. It's not just a UConn, but it's an alignment within UConn itself participating in this. So that's all I have.
Carla, did you have anything to add?
So we did not originally propose to do a patient level survey, but from our advisory groups, I think one of the things that we need to do is maybe consider a patient level survey that assesses safety factors for pedestrian traffic, how far they're traveling on foot or by transit, how many of them are using transportation services, and what kind of barriers they experience there. So there are the rideshare services that are dedicated to many, or can be used by many of the patients for medical purposes. But there's been problems even there with reliability and access, reliable access. So I think it would be a really great enhancement to what we've already been doing to have that patient level experience data to complement what we're looking at here.
Yeah, Carla, I'd also say we've also noticed that there seems to be some variation in reimbursement of costs for transport, either to the agency or to the client. And I think I'm sure that's confusing to the client and can be a barrier to the agency as well. But everybody's committed to doing the transport. I think that's what's really important. Jeff talked about everybody talks. Everybody really shares both their best and the strengths and also the areas that they need to improve on transit. I think pretty openly on our conversations, because for all of them, they're so dedicated to the programs they're running that they just want success for their clients. So I think that's been that's the glue that holds the group together, perhaps more than anything else, just that they care.
That's great to hear. And I'm glad you mentioned the kind of payment and cost issue. Another question I had, I wonder whether you envision engaging healthcare payers in this discussion at some point. If there are cost savings, some of those savings are likely from more proximate transit. Some of the savings are likely going to be accruing to healthcare payers, probably Medicaid as a dominant one here. And Medicaid managed care plans, if you got that in Connecticut, but potentially others. Do you see payers as being, a stakeholder to bring into the mix on this at some point?
Yeah, I believe Medicaid in Connecticut does provide payments, but under certain circumstances and to certain providers, right? So I think that's the confusion. I think there are programs available to many, but they're just not promoted very well. And then the other challenge, as Carla said, is the statewide provider of some of that transportation. We hear reports of unreliability. The client can't get picked up, or the client doesn't get picked up at the right place or the right time, which doesn't help for this particular cohort of group we're talking with. That just adds more anxiety and insecurity to things. So I think that's that's something we're hearing pretty much across the board, which is why as Jeff mentioned, the Uber types of rides, or the lifts that come to your house, pick you up, and take you to your destination seem to be working fairly well from the providers reporting. But then there's the cost. Who pays for that?
Yeah, that was a great question, Glenn, because it's sort of a traditional public finance question, right? You've got these positive externalities that people aren't taking advantage of, and does it make sense to have a higher level of government try to come in and coordinate and help internalize that? And so from that perspective, I see that there could be a huge role for Medicaid to come in and help. So that's something that we'll talk further with about the group and try to figure out who the right people are to pull in for that discussion.
That makes great sense. Well, I know we are nearing the end of our hour. I want to thank our research team from Connecticut for sharing with us your progress on this study to date. Really interesting work, and we look forward to continuing to learn from your study as it progresses. Welcome, folks. We do have contact information from our panelists today. If any members of our audience want to follow up about this study in greater detail, you can reach out to them. You can always reach out again to our national program office for S4A as well, and we can keep you connected into the great work of this research team. Obviously, again, this is a regularly recurring Research in Progress webinar center series. So we invite you to tune in to our upcoming webinars. You can see a couple of them listed on the screen. We have another one coming up on November 10th, and another one on December 8th. Every cycle will profile a different study within the Systems for Action research program and what we're learning from them. Thanks again so much for joining us. Thanks again to our Connecticut research team, Dr. Cohen, Steve Hewlett, and Dr. Rash, and have a great day, and please stay in touch.